we have fun.
There would have a four-way tie.
We have all
We
the
would stand up
events.
and we could give a great like stump speech
Okay,
about
so,
why we need it.
while this thing is working down here, being pulled up, I'm gonna go ahead and start. So, I moved the urogenital system over into this lecture.
This may be old.
This is the old one. This is the old one.
Oh, I switched it, hold on.
Yeah, it was updated on Friday when we moved,
So we're doing,
yeah, hold on.
oh,
Yeah.
it's still under code, it's around, you can roll the full title, so this is.
All right, so we're going to start with the urinary system. The entirety of the urinary system, meaning the kidneys and the ureters and the bladder, is outside the peritoneum. I mentioned that before. In terms of accessing the kidneys or kidney transplants or removal of a kidney, you can operate completely outside the peritoneum. So we're going to talk about those structures, plus the suprarenal gland today, which is sitting on top of the kidney and is also outside the peritoneum, extraperitoneal, retroperitoneal in specific. If you look at the kidneys, about half of them are above or contained within the 12th rib, and half are below. And so when you're doing a physical exam on somebody, and the possibility of pyelonephritis or glomerulonephritis or some other kidney problem is there, one thing you always do is you test the costovertebral angle, the CVA right there. And you do it by you can do it one of several ways. Can you stand up? Do it one of several ways. One of them is after you've examined the patient's abdomen, you come back here and you just hit right there in the costovertebral angle. Does that hurt? Okay. The other thing you can do is put your hand there and hit your hand. That's a little bit less obnoxious. And the other thing you can do that I do a lot is I just take my fingers and sort of dig in there. Does that hurt? If you have kidney infection or inflammation, it's going to cause pain. So remember the CVA. You're always going to test the CVA on any abdominal exam. When you look on the posterior wall of the abdomen, today you're going to remove the peritoneum and just peel it off. And this is what you're going to see. Now this relationship you need to appreciate. If you look at the renal veins and the renal arteries both coming off of the aorta, the renal veins, specifically the left renal vein, lies in front of the aorta. The right renal artery goes behind the inferior vena cava. See that relationship there? So the left renal vein is longer than the right. The renal arteries are about the same length, but the left renal vein is clearly longer. Now one thing about the gonadal veins is that they are, the gonadal arteries, is that they arise from the aorta. I mentioned that the other day, right? The gonadal veins drain into separate structures. The right gonadal vein drains into the inferior vena cava that you see there. The left gonadal vein drains into the left renal vein. Yeah. So if you look at the picture there, the right the right ovarian vein or the right testicular vein drains into the inferior vena cava. On the left side, it drains into the left renal vein. They drain to the left renal vein. So there is asymmetry in the venous drainage of the gonads. Oh, it says it right there. Okay, that's good. Are we back online? Is it good? Okay. All right, so if you look at the kidneys being back here are exposed to trauma. So one way to help prevent trauma is to encapsulate them in fat. And there are actually two layers of fat. There's a perirenal fat and a pararenal fat. And they're illustrated on this slide right here. I don't really care that you know the difference between the two. The important thing here is that the kidneys have two things. They have a fascia called the renal fascia. That renal fascia is right here. You see it outlined in bluish color. It surrounds the kidney and the suprarenal gland. You got fat on either side of that fascia. So if you're going to remove that kidney, you're going to have to come in through here. You're going to have to go through the fat, then the fascia, then more fat, and then you get to the kidney. And the kidney itself has a capsule around it. It has a pretty tough capsule that's around it. You'll see it today in lab. All right. The anatomy of the kidney itself, like the lung, the hilum is where things go into and out of. You'll see the renal artery breaks up into several different branches. The renal vein is coalescing from several different branches as well. The ureter exits the inferior part of the hilum of the kidney and heads down towards the bladder. This part of the ureter here is called the pelvis. Okay? We'll get inside out of here in just a second. You know, interesting, when your kidneys started, your testicles started up here and moved down here. Your kidneys actually started in your pelvis and moved up. And they actually started facing forward, facing backwards. The hilum was facing backwards. They had to rotate. So they're in their current position with the vessels pointing medially.
And you said the pelvis of the kidney is on the posterior side, correct?
Yeah, that's right here.
Okay.
Well, you can, it'll be inside of there. Let me slice the kidney open and you can see it much better. Here's the renal artery distribution. It's extensive. This is only the large arteries, not out to the glomerulus, obviously. You have about, the glomerulus is the functional unit of the kidney. You know that, right? And about 1 million in each kidney. You have about twice as much kidney as you need. Your renal reserve is 100%. So you can remove one kidney and still have no change in your body chemistry, blood chemistry, because you have so much of a reserve. That's why you can donate a kidney and you're still good to go. It's only when you start falling off of that one kidney that you start getting into renal failure. And there are many different levels of renal failure we'll cover when we get to that point. So if we slice open the kidney here, we see a cortex, which is all of this out here, and then the medulla, which is really the collecting part. So cortex, medulla. The cortex is arranged in pyramids. And between the pyramids, you're going to see the columns. When you cut open a kidney today, and cut it open long ways like this, and try not to saw it open, but make it one nice cut. Get a sharp scalpel. That will give you your best shot at preserving the pyramids. The pyramids come to a cone, like a nipple almost, and you see it right here. That nipple has hundreds of openings on it of the collecting system that are going to drain urine into the minor calyces. You have about 9 to 12 minor calyces. The minor calyces are going to drain into the 3 or 4 major calyces. The major calyces drain into the pelvis, renal pelvis, and then on into the urine. Just interrupt me when you need to. All right, so ureters head south. And in the male and female here, they have very specific anatomical relationship to the reproductive end of things. In the females, you'll see right here, here's the bladder, urinary bladder, and there's the uterus. There's the vagina, there's the uterus right there. If this is the bladder right here, and this is the vagina, that's the uterus. The uterus sits on top of the vagina. Oh, excuse me. It does, but it also sits on top of the bladder. And that's why women in the third trimester have to pee every 2 minutes, because they have this 50 pounds of, not 50 pounds, 15 to 18 pounds of baby and placenta water sitting on their bladder. So, if you'll notice, here's the uterine artery right there. The ureter passes underneath it. In this illustration down here of the guy, we're looking at this guy from behind. Here's the vas deferens here, the ductus deferens. You'll see that the ureter also passes underneath it. So water is always under the bridge. Okay. The thing about the ureter is that there is peristalsis in the ureter. You don't just have urine trickling down from the kidney into the bladder. There's peristalsis movement of urine into the bladder. When you have a stone obstructing that ureter, that peristalsis is pushing against that obstruction, and that's why renal pain or ureteral pain is so wave-like. It's like, oh my gosh, this is the worst pain ever, and then it lets up for a second until the next wave comes along. So if the pain is more constant, it's probably not ureteral. So when you're developing a differential diagnosis, if somebody comes in with spasmodic or wave-like pain starting right here, you would think there's a stone. If it's a constant pain, you would be thinking more along the lines of pyelonephritis or an infection that's not associated with peristalsis. All right. If you look at the urinary bladder and you open it up, here's the openings of the ureter, and then down here at the bottom is the outlet. So the urethral opening is at the bottom. Those three structures right there form a triangle called the trigone. The trigone is not a muscular or is not a contractile part of the bladder. The rest of the bladder is. The contractile part of the bladder, all of this stuff up here, is called the detrusor. D-E-T-R-U-S-E-R. Detrusor muscle is the contractile part of the bladder. The trigone is not. And by the way, if this is the bladder wall here, the ureters, they don't just enter like that. What they do is that they come in and they course inside the muscle before they open up at the urethral orifices that you see here at the trigone. And the reason is, when the bladder contracts, the muscle contracts, preventing urine from going back up the ureters. So it prevents ureteral reflux by having that undermining with the muscle itself. Now, a lot of babies are born having ureteral reflux, and the surgical procedure is going in there and rerouting the ureter into the detrusor muscle itself. My sister had that done. Anybody here? You had it?
Oh, no, is it because it didn't go through the muscle? Is that
Developmentally, it just didn't work that way. You know, the odd thing about 10% of all people have a significant abnormality associated with their urinary tract, their urinary system, 10%. And I'll get into that when we do embryology of the urinary tract, but that's a high percentage. Now, the thing about bladder cancer, let's talk about bladder cancer for a second, is that it's almost always due to nicotine exposure. 99% of people who develop bladder cancer are usually in the 60s and 70 years old and smoke. This is one of those things where, you know, like HPV, you're going to have, you know, cervical cancer is caused by HPV 99% of the time. Squamous cell carcinoma, the back of the throat, is caused by HPV infection. Anal cancer is caused by HPV infection most of the time. Bladder cancer is caused by nicotine exposure, a high percentage of the time. Okay? And it 75% of the time, even if you remove it, it comes back. So it has a high recurrence rate. All right? Now, there are different sphincters in the bladder. So there's an internal urethral sphincter and an external urethral sphincter. The internal urethral sphincter is right here in the male, right there well, it's the same place in males and females. It's at the bladder outlet. That's the internal urethral sphincter. When your bladder is full, the autonomics say it's full and it lets go. The external urethral sphincter, though, we're going to see tomorrow, is down here in this little diaphragm, and it's under somatic control. So you can sit there and pinch it off and not pee on yourself. Right? It's the last, I mean, when you let go of the, when you stand, you know, you're at the toilet finally, and you say, okay, pee, and you voluntarily pee, well, the internal sphincter has already let go. It let go a long time ago. All right? So the external is the only thing saving you from embarrassment. Any questions about that? You know, and several things we can talk about tomorrow. Urinary incontinence. Just about everybody over the age of 61, because I'm only 60, has urinary, especially females have urinary incontinence, especially women who've had children. Especially women who have had children vaginally, because what you do is you wind up. You good? All right, thanks. So you wind up weakening these muscles here, and you don't have the tone to your external sphincter that you did as a young person like this. Also, the tone of this area, especially in females, is estrogen dependent. So without estrogen, you know, postmenopausal, you just don't have the tightness of the tissues to maintain continence. And one of the treatments for this is to give a woman estrogen cream to apply periurethral down here, and that tends to absorb into the tissues and tightens things up. Any questions about that? Okay. All right, innervation of the bladder comes from 3 different sources, really. The Detrusor is pelvic splanchnics. The Detrusor is parasympathetic. So in order to pee, your S234, your pelvic splanchnics, go and synapse on a ganglion that sits right beside the bladder or is in the bladder itself. Ganglion, so it's kind of like the GI tract, right? And cause contraction of the Detrusor. At the same time, the sympathetics, when they fire, they contract the sphincter. So when you get ready to pee, you inhibit the sympathetics. That's the internal sphincter. And finally, the external sphincter is innervated by a nerve called the pudendal nerve that we'll get to know tomorrow quite well. We'll see it today, I think, but we'll spend most of our time with the pudendal come off. Okay. So that's the somatic control over urination. And the pudendal nerve is somatic S234. Don't get those confused. There's parasympathetic S234, and then somatic S234, that's the pudendal nerve. Renal calculi, anybody in here have kidney stone? You only one of you?
I've had one.
Two of you? Yeah. Painful, right? You've had children?
Yes.
Which worse?
Um,
See, she's having to think about which is worse. That shows you how bad it is. So it starts as pain in the CVA. Starts as, well, it's this right here. It starts as pain in the CVA, and then as it starts trickling down or rolling down the urethra, the pain starts shifting around the flank until it gets down into the lower part of the urethra. It winds up, the pain winds up radiating down into the labia or into the scrotum. And when it falls, finally makes its way into the bladder, the pain's instantly gone. And then when you pee it out, for a brief second, it hurts again. Did you have this characteristic, did you guys have this characteristic pain? Started up here, kind of migrated down into your growing area, and like ouch. Yeah. Morphine, this is Demerol, this is morphine kind of pain. So. And some people, they have, they throw these things all the time. I mean, they're just like once a month they're having a kidney stone. So, anyway. There are a whole bunch of reasons for kidney stones. We'll talk about those when we do the GU section. Transplantation, here's a kind of funny thing. So, if you're going to transplant a kidney, you would think that you take the diseased one out and you put the good one in, right? Wrong. You leave the diseased one where it is. What you do is you take the good one and you transplant it down here in the pelvis in the common iliac area. You do renal transplants down here, not up here. So I thought it was kind of stunning when I realized that one day. I thought, why you don't even take the old one out? So there you go.
and what's the reason?
Huh?
Why do they leave it in? Why do they leave it in?
Well, there's no reason to take it out. I mean, you would take it out if it was gangrenous or something like that, but if it's just a dying kidney, just leave it in. My wife only had one functioning kidney. She had two kidneys, but only one function. She didn't know that. So if she ever needs transplanted, you just leave the other one in. You know, so it's a little raisin-looking thing up here. So, it's a little strange. So, yes, sir.
Does the non-functioning kidney still produce stones?
Does it still produce
Stone?
urine?
No, stones.
Stones. No. No, because in order to produce a stone, you've got to have urine out.
No.
And when you're talking about renal failure, to the extent of transplantation, the urine output is going to be almost non-existent.
With polycystic kidney disease, do you believe the kidneys in?
No, you just leave them in. Yeah, you leave them in. There are a whole range of kidney diseases. One of them is polycystic kidney disease. I think that one of them downstairs has a big old cyst on one of the kidneys, so when you pull them out today, ooh and ah. Like I said, there are high incidence of congenital anomalies related to the kidneys. There's a thing that's kind of a unique thing. It's called a horseshoe kidney. It's where the kidney never separated into two different elements. So it wraps around the front of the inferior vena cava and the aorta. It can compress things. It can't, like the inferior mesenteric right here, it can compress things and it might require surgical correction. But most of these anomalies are found serendipitously. It's like, oh look, they have a horseshoe kidney. So the pelvic kidney is one that never ascended. One of the most common abnormalities is what happens is when your kidney starts out in the pelvis, if it's down here, it has a blood supply. And then as it ascends, that blood supply goes away, and then it picks up a new blood supply, and then so on like that, right? Well, what happens in a lot of, probably the most common anomaly is you'll have the kidney up here with the artery and vein all the way out of the pelvis. It never lost the original blood supply. You can have duplicate ureters, as you see here, and in any number of variations. This one right here appears to be wrapped around the inferior vena cava. Like I say, 10%. All right, suprarenal glands. We're gonna do a whole lecture on the suprarenal glands when we get to endocrinology. But suffice it to say today, the suprarenal glands or adrenal glands, I don't care what you call them, sit on top of the kidneys. They're flat. Well, they're sort of pyramid shaped, but they're thin. They're more thin than pyramid shaped. They're about the size, a little bit bigger than a quarter, and they are really pyramidal shaped. If you cut them, if you look at the vascular supply of the adrenal glands, they have a huge arterial vascular supply coming from 3 different sources. The inferior pharynx, the aorta, and the renal arteries all give a branch into the suprarenal glands. Those 3 arteries give a branch into the suprarenal glands. The suprarenal vein, there's only one vein. It drains into the inferior vena cava on the right, left renal on the left. The suprarenal vein, there's only one vein for each one. On the right, it drains into the inferior vena cava, like the gonadal vein. On the left, it drains into the left renal vein, like the gonadal vein. Here's what they look like here. It's a bloody mess. So there are 2 parts to the adrenal gland. There's a cortex and a medulla. You see all these autonomic nerves here? They're related to the medulla. The cortex is under hormonal control, not really vascularized that much, other than the blood vessels going to it. It's the medulla that's so well innervated. And it receives innervation from 2 different ways. One is that this is the medulla right here. You have sympathetics going to the blood vessels, just like any sympathetics going to any other blood vessel. They're postganglionic. They would have synapsed at the celiac ganglion because it's right there. Okay? But the other thing, the other type of innervation comes from the splanchnics. And the splanchnics are preganglionic. They synapse, and I'll put that in quotation marks, synapse on the adrenal medullary cells. The adrenal medullary cells, they're called chromaffin cells. I don't know if that's up there or not. Chromaffin cells act like the postganglionic sympathetic cells. So the adrenal medulla functions as a postganglionic sympathetic. You know sympathetics are fight or flight, so that's got to be epinephrine, right? Get your everything pumping. What's released from the postganglionic cell is epinephrine, or norepinephrine, adrenaline. That's where it's functioning here. Think about it for a second. You know how when, it's like this morning, at 1:30 in the morning, my wife sent me a text. She's sleeping downstairs in a bed because she's got had surgery, got this cast on. She can't climb the stairs, and I can't carry her. So I was upstairs sleeping in the bed with the dog. So at 1:30 in the morning, I get a text from her that she's got restless legs, and she's going to take 37 Lortabs so she can go to sleep. And I'm thinking, that's probably not good. So I go walking downstairs, and it's dark in the house, And she's in a wheelchair, she's wheeling herself into the kitchen to get a Diet Pepsi, which is the drink of the gods. She rounds the corner, and there I am. And all of a sudden, it's like, ah, right? And you all had that, you know, and all of a sudden you feel like that, ah, right there, right? You feel it right there. Well, you feel it right there because you just dumped a ton of epinephrine out of that. Where did that go? It went right into the inferior vena cava or renal vein, which are right below the diaphragm. It went right to your heart, and you got that started, right? Your heart missed a beat, or whatever you want to call it. Okay? There you go. Okay, also on the back wall, there are these nerves. And there are several nerves back here. Some of them we need to find, some of them not so much so. If you start from there's the 12th rib right there, so the first one down is the subcostal nerve, very easy to find. Then you'll find the iliohypogastric and ilioinguinal. Those are the nerves that, remember, they're wrapped around the front part of the body here. We don't really need to pay much attention to them back there. But there's a nerve that runs right across the iliacus muscle. It's called the lateral femoral cutaneous nerve of the thigh. Just supplies the thigh skin out here. And there's going to be the big femoral nerve. Femoral nerve is big as Dallas. Here's the psoas major muscle right here. Remove it from one side to find the femoral. Remove that psoas muscle, major and minor, to find the femoral. It'll be about as big as this thing right here. It's big. Now, right below it, or inferior to it, is the obturator nerve. The obturator nerve goes into the pelvis. I'll talk about it in just a minute. There's a huge lumbosacral trunk back here where the L4 and L5 join S1. They form a huge nerve back there. You probably won't see that. That's okay. The other thing, though, is I mentioned to somebody the other day, sitting on top of the psoas was the genitofemoral nerve. That's the nerve that goes to the cremaster muscle. Okay? You can find that one today pretty easily. Really, the three that I want you to focus on, though, are the subcostal, the femoral, the obturator. Those are the three big ones. Okay, any questions about the posterior abdominal wall? Yes, Paul?
Do the vein obstructions on the left go to the renal veins, like the aorta and all that, because they don't want to cross over the aorta? Like they don't want to minimize the amount of crossover?
I think it has more to do with the embryology of the area.
Okay.
When you were a little, like 5-6 weeks old, you had these different venous systems called cardinal veins. And when we do the embryology of the circulatory system, you see how it all started out is nothing like it is in an adult. And I think probably what happened was just the parts of the cardinal veins that form the left side are different than that forms the right side. You actually started out 2 aortas and 2 inferior vena cavas that eventually merged as one. So, okay, orientation to the pelvis. We know about the diaphragm on top. You also have diaphragm at the bottom. So you have a muscular diaphragm, respiratory diaphragm at the top, and the pelvic diaphragm is inverted below. That pelvic diaphragm is what keeps your insides from falling out a big hole in your pelvis in the bottom. That muscular diaphragm. It has several pieces and parts, and we'll go over those in just a second. First, let's talk about the pelvis itself. There's a false pelvis, and that's the part that's up here high where the iliac crest is. That line right there is called the arcuate line. If I show you on the next slide, I think it's on the next slide, right here. This is the arcuate line right there, that ridge. Above that ridge is the false pelvis. Below the ridge down there is the true pelvis. don't think anybody's ever going to ask you about the true pelvis or false pelvis. What they will ask you, though, is the pelvic inlet and outlet that you see described here. Inlet and outlet. The pubic symphysis is the part of the two pubic bones that come together as cartilaginous. It's about 1 centimeter in width. And then I mentioned to you before, the space down here below, behind the scrotum, or between the vaginal opening and the rectum, right there is the perineum. That specific place is called the perineal body. Behind the scrotum, in front of the anus, that fibrous area is called the perineal body. The whole area down here is the perineum. All right, so if we look at the pelvis itself, two words to use to describe this are os coxae, C-O-X-A-E, O-S means bone. Os coxae, that's what describes this thing here. And it's a ring made up of essentially 7 bones. You have the sacrum that we know there. The sacrum has this part out here. It's called the sacral ala, A-L-A, meaning wing. Sacral ala. It attaches to the ilium. It attaches to the ilium. This thing right here you feel going up and over is your iliac crest. That's your iliac crest. In the front, the iliac crest becomes continuous with the pubic bone. And down here, the bottom part, this is the ischium. So this is the superior and inferior ischiopubic ramus. Superior and inferior ischiopubic ramus. The hole in the middle is called the obturator foramen. The ischiotuberosity is what you're sitting on right now. The 2 bones you're sitting on. Right in front of or above the tuberosities, you see that little thing right there? That's the ischiospine. Ischiotuberosity and ischiospine. All 3 of these bones, the pubic, ischium, ilium, come together to form the acetabular fossa. So if you look at a head-on view of the acetabulum, it's like that. Each of the coxal bones contributes 1/3 to form the acetabulum. And you can tell males from females by looking at this angle right here. In females, it's more U-shaped. In males, it's more V-shaped. So that angle is, when they said, skeleton was found, it was a female. How they know it was a female, all you gotta do is look at that angle right there, and you know right offhand. Okay? That's kind of cool. And during parturition is the act of having a baby. The hormones cause the ligaments in the pubic symphysis to become lax, and it can, during the passageway, the thing will widen out several inches. It's pretty cool to see. So. It also becomes lax back here. So as the front is opening up, you've got to have the back to relax, or it won't let go of itself. Now remember what I told you about a contrecoupe or a ring-type lesion? This is a ring, so if you're not having a baby, if you fracture the pelvis over here, you run a pretty good chance it's going to be fractured someplace else. Pouring right over top of this angle here, this arcular line, you're going to have large structures like the internal iliac artery and vein. 50% of pelvic fractures, those people die in the field from exsanguination because it ruptures these big arteries. 50%, that's huge. All right, I think we've kind of been over all of this stuff right here. This is interesting thing about the ala of the iliac bone is that this is the last, right there at the top of that bone is a growth plate. That's the last growth plate to close in a human. And it closes at about the age of 19 at the top of the iliac crest. So when you get when you're shooting a pelvis of a teenager or so, you'll see it looks like a double line. You'll see the iliac crest just comes up like that, and then you'll see one above it. Well, that's a growth plate, a pivot plate right there, and that's the last thing to close, the iliac crest. Okay? And that's, by the way, the closure of bones, of growth plates, is very regular. And that's how they can tell the age of a person up to 19, is by which plates are closed and which ones are open. So if that's closed, you know they're older than 19. The sacrum, we probably beat this little dead horse, this horse to death, haven't we? The ventral primary rami, dorsal primary rami come out of these ventral and dorsal sacral foramina. And there you go. The sacral promontory is the, one thing about this that is important, is this sacral promontory, if you look at the pelvis itself, this is the sacral promontory right there. It's S1. When you do a pelvic exam, especially if you're dealing with pregnancy, and I'll talk about this here in just a second, if you put your fingers in the vagina, and here's the pubic bone, this part goes under the pubic bone, and you push backwards, you can feel the sacral promontory. Okay? It's not that wide. It's like 10 or 11 centimeters, that's it. So when it comes to having babies, that's kind of an important thing. There are two ligaments that you're going to find maybe today, if not today, tomorrow. There are actually three. One of them is the Obturator Foramen is covered by a ligamentous membrane. That membrane is open in the top. And that's for passage of the obturator nerve and artery and vein. That little hole in the top. Now, when you have your cadaver in the prone position, face down, and you remove the gluteus maximus muscle, there are two ligaments you're going to find. One of them runs from the sacrum to the ischiotuberosity, and one runs from the sacrum to the spine. That's called sacrotuberous and sacrospinous ligaments. If you look back here on this slide, it illustrates. It notes two different things called a greater sciatic notch. There's the spine, and there's the lesser sciatic notch, and there's the tuberosity. If we put those ligaments in place, it changes the notches into foramina. So there's the greater sciatic foramen, and then the lesser sciatic foramen goes between the sacrotuberous and the sacrospinous ligaments. I don't think you can feel these ligaments on you. No, you really can't. But you're going to see in the cadaver that they are of the utmost importance.
So they come foramen when you put the ligaments on?
Yeah, when you put the ligaments on, the notches become foramen. And there are a whole bunch of sacroiliac ligaments here you're not going to see. All right, so here's the pelvic diaphragm. So let me go over this and we'll take a break. So this is inside the pelvis. We've taken everything out and we're looking inside the pelvis. Now this is what I want you to do today. There's the string, you know, the twine is sitting over there on by the bone boxes, right there, the twine. Take 2 pieces of twine about that long, about a foot long, as far down in your pelvis as you can reach. If this is the rectum, tie a knot, tie it off, hard as you can, right? Poke it, you know, get around it and tie it off. And then tie it off again about an inch above it. And then cut it through there and then remove all of that from the pelvis. Pull it out of the pelvis, okay? If you don't tie those ligatures tight, though, you're going to have a mess on your hands. So tie it well, my friends. And that's what they've done here. They pulled it all out, okay? So here you see, there's the sacrum. The pubic bone is there. Here's the superior pubic ramus. There's the ilium right there. There are 3 muscles that you're going to run, well, 4 that you're going to run into. One of them is this one that sits on the inside of the obturator foramen. That's called the obturator internus muscle. Obturator internus muscle. And there are 3 muscles that go to form the pelvic diaphragm, which is what this thing is. There's the pubococcygeus right there. Its most medial parts is called the puborectalis. And let me explain that to you. Here's the pubic bone right here. Here's your anus, here's your vagina, here's your urethra. This is the pubic bone, the pubic ramus, right there, right? The pubococcygeus comes off of that, just wraps around that, like that. It forms a sling. That's the pubococcygeus. The part that essentially in touch with the rectum itself is this part right here. That's called the puborectalis. The puborectalis. If you look at the colon or the rectum from the side, here's the sigmoid. There's the sigmoid colon right there, and then it's got this 90-degree turn formed by that puborectalis. By that thing pulling traction on it, that keeps you from leaking all over yourself as you're running down the street. Okay? To poop, you relax that, and it straightens up, and you go poop. Right? So, puborectalis is just a medial part of the pubococcygeus. Now, off to the side, here, is the Elio Coccidius. Off to the side is the Elio Coccidia. Here's the Elio Coccidia right here. This is the Elio Coccidia. Here's the iliac crest, so it's from the ilium. Now, the odd thing is, look where it is. It's actually coming from the obturator internus. You see right there? It doesn't come from the bone itself. It comes from the obturator internus. There's actually a tendon right here. There's the obturator internus, because there's the obturator canal with the obturator nerve artery vein. There's a tendon right there. So the Elio Coccidia arises from the internal fascia of the obturator internus. You can see it in the lab pretty clearly. So these two muscles, the pubococcygeus and the iliococcygeus, make up the levator ani. If you're sitting there in your chair and you pull your anus up, do it. Pull your anus up. Those are the two muscles that are doing it. Okay? You can let it down, Paul. You had it up around his highway, Paul. Let that go. There's a third muscle, though, that forms part of the pelvic diaphragm. That's back here, running from the greater tuberosity of the ischium over to the sacrum. That's called the ischio-coccygeus. Okay. Follow me here. That muscle has nothing to do with your rectum. So it's not part of levator ani, but it is part of the diaphragm, the pelvic diaphragm. That would be the ischio-coccygeus, sometimes just simply referred to as the coccygeus. And if you had a tail and you wanted to wag it, that's the muscle that you would use, the coccygeus. Huh?
She has a tail.
You do have a tail.
No, I was smiling because my dogs.
I know, I sit there, my Beagle wags his tail all the time. And I sit there and watch it where it goes into his body, thinking that's his coccygeus. The pelvic diaphragm is somatic. Like the respiratory diaphragm, it's somatic. It's the pudendal nerve that innervates it. S234. What?
Pudendal is such a funny word.
Well, here's a better one. S234 keeps the pelvis off the floor, because this is holding all your stuff in. Okay? I didn't make it up. You can see it right here. There's the coccygeus right there. Also called the ischio-coccygeus. All right, take a break.